Welcome back to VoiceWhat presents the great business story Transforming India in association with NDTV Profit. Now, if India is to be a developed country, it has to provide healthcare to all its citizens, which has to be affordable and accessible, irrespective of where they live or what strata of society they come from. That is where iKure steps in. Joining me now is Sujoy Shatra, founder and CEO, iKure Techsoft. And can you tell us a little bit about your mission and how you plan to provide healthcare facilities, especially to people who live in remote areas, the last mile connectivity as we talk about?
India, with a population of more than 1.4 billion plus people, wherein more than 70% of the people who are staying outside of the tier 1 cities, which comprises of around 840 million plus people, on an average, each people and the patients, they have to travel for more than 20 to 25 kilometers to seek the basic access to care in terms of the primary health care. So that is where iKure is aimed to provide affordable, accessible, quality primary health care to these underserved populations in India.
Now, can you tell us, sir, how iKure plans to integrate technology, especially through WHIMS, and take this healthcare services to the underserved areas, the underserved populations, which is where it's required the most?
iKure, over the years, we have designed and developed a very strong, scalable and sustainable primary healthcare model through a combination of frontline community health workers. So these health workers are actually selected from the communities, mostly village women, who are selected, trained, and they are deployed as community health workers who are carrying backpacks with various medical equipments and smartphone with our own indigenous platform. So they are able to provide 3 services. The first is the community mobilization, wherein they are able to educate the communities. The second is capturing of the vitals and integrating that through our integrated platform. And in case the patient needs any kind of teleconsultation wherein they can speak with the doctor, so we are able to provide aided telemedicine. On top of that, once the doctor is able to see the patient, they are able to issue a prescription, and these health workers are able to deliver medicines and various other supplies right at the patient's doorstep. So through a comprehensive integrated community health worker model, through our integrated doorstep services as well as at our clinics, and then providing the services up to the referral points at our partner hospitals, we are aiming to provide a complete continuum of care services across the last mile in India.
Tell us a little bit about, how are these services, sort of taken, like you said, especially in terms of preventing and screening, healthcare issues. How is that taken to, the rural communities, the last mile communities?
India is a country which is very different. So we have developed what we call as a bottom-up model, wherein our technology is extremely robust. It works across extremely low resource settings, right from the offline model to hybrid models. We are able to deliver services in some of the most remote areas, and our technology platform has been designed to be very, very user intuitive. With simple basic training, which comprises of just few weeks of training, we are able to transform these community health workers. So here I would like to give an example of our telehealth services which we carried out in the Nagaland for the entire state of Nagaland during the middle of the pandemic, wherein we had to work with the government of Nagaland to provide healthcare services across 192 centers and the sub-centers.
Tell us a little bit about these healthcare workers and what kind of training do they receive, and how do they interact with people, and how do they fit into this whole system of providing healthcare and improving healthcare in the last mile to the last person in the rural, remote, unreachable areas?
So here we had this very difficult task to transform these village women and train them as community health workers. So in the initial period of our journey, it was extremely tough. We were thinking that many of them, they have never seen a phone, let alone a smartphone. The simple gestures, swipes, which we are so obvious, that was not so easy for them. So we had taken that impossible task to train them and educate them through technology. So as part of the training, they are able to provide the history taking, which is capturing of different vitals through our platform, as well as integrated technology. And during this period of our transformation, we understood that some of these health workers, they were able to pick up those skills and they were able to educate others.
How do you keep it affordable,
Right.
and effective?
Right. So iKure is a for-profit social enterprise, and in the last few years alone, we have already broken even and we are in the profits. And how we are able to do that is through integrated model. We have two models, which is the B2C, wherein the patients are paying for the services. So for us, our target market is the middle layer, which is if you remove the top 10%, which is the creamy layer, and the bottom 20 to 30%, which is the base of the pyramid. So the middle layer, wherein the average income of the family is more than 10,000, they are able to afford iKure services through these community health worker model. So that is why we have designed a volume-centric model, so that we are able to pass on the benefits. So that now they are able to get comprehensive care, which is market competitive, as well as they are able to get discounts on medicine, supplies, and many other things at an affordable price right at the doorstep. So this is how we have created the volume-centric model. On the B2B side, wherein we are offering services in some of the most remotest parts in partnership with corporate, in partnership with multilateral agencies, and with the support of the governments, we are able to comprehensive care. So through these mechanisms of the B2C model and the B2B, we are able to provide a strong, scalable and sustainable model. We have understood that unless and until you are able to make the systems and the solutions very simple, wherein the moment the vitals are captured, be it blood pressure, temperature, SpO2 and many others, we have been able to integrate those devices into a platform which ensures that the health worker has zero or minimal manual intervention to capture the data. But unless and until you are able to ensure that the data captured on the ground is seamless and accurate, you can never build a data platform, you can never build an AI platform. That's why iKure has taken those technologies very, very seriously, wherein the data that is being captured has to be seamless, has to be accurate, so that the analysis, the visualizations and everything that can be carried out by the government agencies, by the research organizations, medtech, pharma and many others.
So obviously one of the areas is maternal health and child healthcare, and these are concerning areas in terms of the healthcare scenario in India.
Yes.
So I believe you've had success in that area. So tell me a little bit about the success and what stands out as far as maternal health and child healthcare is concerned, and your intervention specifically towards maternal health and child healthcare.
Within the maternal health programs, we have worked with MSD for mothers who have been pioneering and providing us a great support to deliver integrated primary healthcare for maternal health. I'll give you some of the examples wherein we partnered with Government of Jharkhand to provide such services in some of the remote tribal populations. So iKure's community health workers worked in close coordination with the ASHAs and ANMs to identify high-risk pregnant mothers, leverage of the technology to bring specialist care and attention, and thereby we were able to bring those first trimester pregnant mothers into the mainstream, so that we are able to take care of them.
What are the chronic diseases that you've noticed or you've had to address in the communities that you're serving?
India is the diabetic capital of the world, and the problem is that especially in the beyond tier 1 populations, we have seen very high cases of diabetes, hypertension, cardiovascular issues, wherein our objective is that if a patient has high blood sugar, you cannot expect that patient to travel to the hospitals every day. That is impossible. But iKure has designed comprehensive care as a sustainable care model in a SaaS-based model through these community health workers, wherein our objective is that once we register these patients and onboard these patients, we are able to measure the vitals, we are able to understand that what are the different levels of criteria or their profiles are, and based on that we are creating a workflow so that these health workers are able to routinely visit the patient's doorstep, capture all the vitals, and in case the patient needs access to GPs, diabetologists and many other specialists, they would be able to provide comprehensive care and diagnosis program, so that the patient is always under the close coordination and monitoring of these doctors.
So I'm told that you plan to treat 50 million patients and I think impact about 200 million people in the next 5 to 7 years. Now that is going to require scaling up. So what do you foresee in terms of challenges to this scale up?
Absolutely. So as iKure has now created a very strong, scalable and sustainable model, so our community health workers are designed to work and become sustainable as community health entrepreneurs in the period of 2 years. So through these combination of comprehensive services, we are already have 60 of them which we have recently launched, and our objective is to deploy 300 in the next 5 to 6 months, 1,000 in the next 1 year and 10,000 in the next 4 to 5 years. So each community health worker can see anywhere between 10 to 15 patients per day. So we can do the maths that how we would be able to reach such numbers. These community health workers, just maybe few months back, they were just homemakers with zero income, and now they have started being and delivering services as community health workers. They are able to buy phones, they are able to buy bicycles, they are able to afford for their education through their own money. So that is the transformation that we are able to bring to these households, especially when it comes to community health workers. And as we are really scaling up, our objective is to become the synonym of primary healthcare, not only for India but across the globe, because now our technology is already aiming to be used in several countries in Africa, as well as our technologies requested for expansion in Malaysia, Indonesia, Philippines and several other regions.
Thank you so much, sir. Thank you so much for your time. And I think, like we were talking about, compassionate capitalism, technology, all of it coming together. So great to see this happening. And thank you so much for speaking to NDTV.
Thank you so much. Thank you.